This opportunity to thank my Professor Devi Meenal Madam and Professor Gopinathan Sir for calling me back to my alumnus and giving me an opportunity to talk and straight on to the topic. Now this will be a case-based discussion how to approach an ILD case. So this is a frontal radiograph and a mini image. Any clue? The finding which I wanted to stress upon, marker area. Okay. So I would have straight away given only the frontal radiograph, but this upper lobe portion where emphysema was predominant was not that much evident in radiograph, and hence I have given the mini image. So you can see the upper lobe emphysema changes and lower lobe fibrosis changes. Now any idea what the diagnosis is? Yes, it is combined pulmonary fibrosis with emphysema. Now next question, what is the Fleishner Society guideline for typical UIP pattern? So the imaging findings in this case is we have an upper lobe emphysema, lower lobe honeycombing or fibrosis, and our diagnosis is CPFE. Fleishner Society guideline classifies the fibrosis pattern in UIP into typical, probable and indeterminate, which we'll be discussing subsequently. Now the most important finding is basal and subpleural predominance of honeycombing with associated reticulations and traction bronchiectasis, and there must be absence of any other findings to suggest an alternative diagnosis. The next question is complications of CPFE. So whenever you report an ILD, it is mandatory to measure the size of main pulmonary artery to assess pulmonary arterial hypertension, which is seen in most ILD cases, and CPFE in particular is seen in smoking patients, and they are more prone to develop lung carcinoma. And when a CPFE patient is exposed to some radiotherapy or any drugs that insults the lung, they will develop acute lung injury. Now the treatment options, there are several options based on the symptoms of the patient. I would like to stress upon the two antifibrotic drugs, pirfenidone and nintedanib, which mechanism of action is not very clear, but they are useful because they reduce the fibrosis activity in all ILD patients. And the only main resort treatment for CPFE is lung transplantation. All other things are symptomatic, giving bronchodilators, advising them to stop smoking, and corticosteroids or inhalational or any other bronchodilator is symptomatic. The most important treatment is start an antifibrotic drug and ask them to wait for suitable allograft lung transplant. Now when you suspect ILD in a case, you have a set of findings to say or suspect ILD. These are the findings. You classify them into fibrotic and non-fibrotic ILDs, and always history remains an important point in giving a diagnosis of ILD. You should always ask for smoking history, drugs prone to insult lung, and connective tissue disorders. So these 8 findings will point towards the diagnosis of ILD. Now these are the common, when you see honeycombing, traction bronchiectasis, reticulation, you are pretty sure it is fibrosing ILD. Those fibrosing ILD will fall into any one of this pattern, UIP pattern, NSIP or chronic hypersensitivity pneumonitis, pneumoconiosis or chronic pulmonary sarcoidosis. When acute hypersensitivity pneumonitis, sarcoidosis, respiratory bronchiolitis related ILD are all non-fibrosing ILDs. But this is not a dictum. Over course, these non-fibrosing ILDs may become fibrosing ILDs. Now, apart from the questions that I have put in CPFE, these are some of the salient points about CPFE. This prognosis is very, very poor because they have emphysema as well as idiopathic pulmonary fibrosis. The most common ILD pattern associated with CPFE is UIP pattern. And there are 2 types of CPFE, emphysema dominant and fibrosis dominant. There are studies on the way to quantify whether it is emphysema predominant or fibrosis predominant. Now this is what is Fleishner Society guidelines, and I have added in red the American Respiratory Society and European Thoracic Society criteria. All these are new updated criteria, and they finally updated only in 2018. The important points are basal and subpleural predominance and honeycombing reticular pattern with peripheral traction bronchiectasis and absence of any other findings to suggest alternative diagnosis. You call it typical UAP pattern. It is always mandatory to mention whether it is typical or probable or indeterminate, not just UAP pattern. Next, when there is no honeycombing but all other features of typical UAP, you call it probable UAP. Only honeycombing is absent. You have basal subpleural predominant reticulation with traction bronchiectasis. So this is a case we received last week. He is a 70-year-old gentleman who is a chronic cigarette smoking person, and the imaging in ILD is very vital. You should always acquire volumetric imaging so as to quantify the fibrosis. The quantification softwares are available. The most commonly used is Salify's quantifying software, and prone imaging is mandatory when you suspect ILD because fine subtle reticulation and interstitial thickening are more evident in prone imaging. So whenever we suspect ILD, we always take a supine and a prone imaging, volumetric acquisition, 1 mm cuts, and here you can see asymmetrical honeycombing in the basal and subpleural location. Can anybody define honeycombing? Fleischner Society have given a beautiful definition for honeycombing. So honeycomb is nothing but it is a layered stacked cells which share the walls without subpleural sparring. So there is no subpleural sparring. It seems like the cysts are stacked one upon the other. They are layered stacked cysts with shared walls without subpleural sparring. Now there with the image, I had only this image from a list to show you this case. What are the imaging findings? So apart from proximal and peripheral bronchiolectasis, there is some superimposed reticulations with GGO. What is this? That is dilated esophagus. The patient also has some skin lesions. So what is the diagnosis? So yes, this is scleroderma related ILD. Any idea how many types of scleroderma are there? Diffuse and limited. Please don't call it as a Crest syndrome. Crest syndrome, esophageal involvement will be there, but that is a limited disease. So you should call scleroderma related ILD. So these questions are for OSCE. You have to know all this. Mention the ANS helpful in diagnosing. Scleroderma 70 antibodies, centromere antibodies, topoisomerase 1 antibodies. These are all for exams we have to know. And most common GI manifestation is dilated esophagus. Esophagus is a predominant site of involvement in scleroderma in the GIT. There will be muscle atrophy and the peristalsis will be less and there will be dilatation of esophagus. Apart from NSIP pattern you see in scleroderma, there are indirect involvement of lung due to recurrent aspiration. A patient known scleroderma without NSIP pattern, you should look for aspiration pneumonitis changes due to dilated esophagus, muscle atrophy, loss of peristalsis. Now this is a new sign they have come forward with what is four corner sign. I will show you the image in subsequent and mention the prognosis of this condition. I wanted to stress that there are two entities, diffuse disease and limited disease. Diffuse disease, as we know, it has a poor prognosis. As I said earlier, Salify's grading is used to grade the prognosis. In that they calculate the entire lung volume. They also measure the non-fibrotic lung volume. They reduce the total from non-fibrotic and arrive at a percentage of lung involved in fibrosis. So these are the common entities, connective tissue disorder that may lead to ILD. All ILDs except rheumatoid arthritis, NSIP is the commonest pattern. Whereas in rheumatoid arthritis, you get usual interstitial pneumonia pattern. Now when you see findings like this, which are suggestive of interstitial lung disease in a young patients, say 30 or 40-year-old patient, you must try to find out some associated conditions, most commonly connective tissue disorders, and secondly drugs, smoking, etc. Now these images will tell you or give you a clue that these are connective tissue related ILDs. First one is anterior upper lobe sign. Anterior segment of both upper lobes, there will be fibrosis and honeycombing. Anterior upper lobe sign, most commonly seen in patients with rheumatoid arthritis, and they will present with UAP pattern of involvement. Next is four corner sign. Anterolateral and posterior superior segments are involved. This is seen in scleroderma mostly. Now this is exuberant honeycombing. Honeycombing itself is a poor prognostic factor, which is usually seen in the basal and subpleural location. When it is extensive and exuberant, you get to see it in the mid and upper zones also. Now this is straight edge sign, which is more seen in NSIP pattern. There is a clear-cut demarcation between the fibrosis interstitial thickening and the normal lung. This is straight edge sign. So anterior upper lobe sign, four corner sign, exuberant honeycombing sign, and straight edge sign will give you a clue. It is a connective tissue disease related ILD rather than an idiopathic pattern, particularly in younger patients. So this you all know, NSIP is cellular and fibrotic. So lower lobe predominant with immediate subpleural sparing. This is again very important. There will be lot of overlapping features between probable UAP pattern and NSIP pattern, and this immediate subpleural sparing will help you give a clue. So this patient presented with chronic cough. On supine imaging you see some basal reticulations with superimposed ground glass attenuation, which is not that clear. On prone imaging you can see mild bronchiolectasis with interstitial thickening and interlobular septal thickening. So we gave the diagnosis of NSIP. Why not a probable UAP pattern? It is not, honeycombing is not there, reticulations is there, mild traction bronchiectasis is there. It is basal and subpleural location. Why not it is a probable UAP? As I mentioned earlier, you can see a clear subpleural spanning in this case. So this is a clue for NSIP pattern. So this is a third case. 48-year-old female from this location with chronic cough. I have given the key HRCT images. This is a spotter, I suppose. What do you see here? Eggshell calcification of nodes. What is this? Irregular bilateral upper lobe soft tissue mass, right? Then what is this? With surrounding emphysema. It is due to, these masses are due to silica deposition, and these emphysema changes are called as focal dust emphysema. Now what are the differential diagnoses? No need of differential diagnosis, you can straight away give the diagnosis. It is a progressive massive fibrosis due to silicosis. What are the predisposing condition? What are the predisposing conditions? Heavy metal mining and hard rock mining. This lady was supposedly working in a sand mining industry, I think. Now what is ILO classification? This is International Labour Office classification. Medical officers get trained there to certify whether it is, silicosis is a notifiable disease. You have to notify if you report a silicosis, and compensation will be paid to them based on the involvement. They are classifying the disease based on the opacity type, whether it is small, regular, irregular, like that, and profusion and extent of involvement. Now in silicosis there are two types, simple silicosis and complicated silicosis. We have seen a case of complicated silicosis. Simple silicosis, you will have upper lobe predominant perilymphatic distribution of nodules with hilar or mediastinal lymphadenopathy. So when you see a nodule, first look at the distribution, whether it is an ill-defined nodule or a discrete nodule. Ill-defined nodules that are diffusely distributed, and discrete nodules you will have locations. When it is in the perihilar, subpleural, perivascular and septal, you call it lymphatic spread or lymphatic distribution or perilymphatic nodules, and other randomly distributed nodules and clustered nodules. So these are the key diagnoses, but you cannot say hypersensitivity pneumonitis will always have ill-defined diffuse nodules. So in case of ill-defined diffuse nodules, hypersensitivity is the most common probability. Next, this is a scanogram. I could not get the X-ray and it was not that evident in X-ray also. Any idea? Last row, could you make any findings? Concentrate on the upper lobes on both sides. RDALD will not be that evident in X-ray at all first. Even in HRCT will be finding it difficult to differentiate infection and RBALD. Okay, these are the questions I wanted to ask. Now give me the diagnosis. Now you see the distribution, notes. What is 1, 2, 3 pattern, 1, 2, 3, 4 pattern? Sarcoidosis. Now we will come back to that scano. Now you are able to see the micronodules distributed in both upper lobes with some eggshell calcifications here and there. Getting it? So the findings are calcified mediastinal lymphadenopathy. Always in sarcoidosis you have to give the staging. Can anyone tell the name of the stage for sarcoidosis? That is my next question. It's CADing criteria, CADing staging. Initially it was only used for plain radiographs. Now it is allowed to use for CT also. Our patient had both nodal involvement and pulmonary lesions and hence it is stage 2. The differential diagnosis are miliary tuberculosis and pneumoconiosis. Now this is a new sign, cluster of black pearl sign. On administration of contrast, you will see some low density areas within the enhancing node that is called as cluster of black pearl sign. This is SCADing staging. Stage 0 is no abnormality, only nodal involvement is stage 1. Both nodal and pulmonary lesion is stage 2. Pulmonary lesions only stage 3. Advanced fibrosis and involvement of cardiac area and all, you give stage 3. These numbers are chances of resolution to normal lung with treatment. So when it is only pulmonary lesions, it is only 20%. So these are other signs that can be asked in sarcoidosis. You want to know a clustered constellation of nodules with scattered small micronodules over it. This is called as galaxy sign. The clustering is also called as clustered sign. Lambda sign, right paratracheal lymph node with bilateral hilar node on a PET CT is lambda sign. This is a black pearl sign that I mentioned earlier. On contrast administration, you will see low density areas within an enhancing node that is called as cluster of black pearl sign, and nodular reverse halo sign. Clustered nodules with surrounding denser lesions you call nodular reverse halo sign. Case 5. This is a 21-year-old female patient, PLHA patient with chronic cough. I will tell you the findings. There are diffuse scattered areas of ground glass attenuation with perivascular tiny cysts. Yes? Yes, LIP. Very good call it is actually. So the diagnosis is lymphocytic interstitial pneumonia. The most common association we know is Sjogren syndrome, but it is also commonly seen in PLHA patients, for young patients, and other associations are SLE and rheumatoid arthritis. We first gave differential diagnosis of pneumocystis pneumonia and the physician started with cotrimoxazole. It didn't settle and he came back with the fill. We again told it can be a lymphocytic interstitial pneumonitis and no treatment for that. They settled happily with the diagnosis. And the complications are, they can progress to end stage irreversible ILD and lymphoma. This lymphocytic interstitial pneumonia is also included in the neoplasm lists of the lung in the recent WHO classification. Now these are comparisons of cystic diseases of lung. So look, as we discussed, our patient is a female patient with perivascular cyst and a predisposing factor. A male smoker with bizarre shaped upper and mid zone predominant cyst with sparing of bases, costophrenic and cardiophrenic angle. Basal sparing, bizarre shaped cyst in a male smoker evolved with the diagnosis of LCH. In addition, they will have multi-system disease predominantly involving the bone and the pituitary gland. This lymphangioliomyomatosis you see in female and non-smoker patients. The cysts are uniformly distributed. They are round shaped, unlike the bizarre shaped cysts in the LCH. The most common, so mostly it can be sporadic. Sometimes it is associated with tuberous sclerosis also. You have to check for the findings of tuberous sclerosis when you see uniform round cysts distributed like this. This is the last and final case. This is the clue here. Forgive me for the artifacts. This is one of the rarest ILD. Yes, pleuroparenchymal fibroelastosis, which is characterized by apical pleural thickening, predominant upper lobe architectural distortion with proximal traction bronchiectasis and peripheral bronchiolectasis and scattered areas of reticulations. There is diffuse interlobular septal thickening as shown. This is pleuroparenchymal fibroelastosis. Now, what is the differential diagnosis? We all being in India, when you see a film like this, we are endemic for a particular condition. We call it post-infective sequelae due to tuberculosis. And then how do you confirm this is PPFE? Okay. Confirmatory test. You go do a biopsy. You go take biopsy from this apical pleural thickening and the HPE will show elastin. The presence of elastin on the tissues obtained from the thickened pleura is confirmatory of pleuroparenchymal fibroelastosis, and be aware of post-procedure pneumothorax and bronchopleural fistula. For any ILD, when they ask you treatment, you can straight away write no specific treatment, give steroids. But in this case and in CPFE also, lung transplantation is ideal. When the patient is going in for end stage pulmonary fibrosis, the only viable treatment is lung transplantation. As I said earlier, antifibrotic drugs and all other symptomatic things you can write when asked for treatment. So the differential diagnosis mostly they will give a primary diagnosis of post-tuberculous sequelae and all these as secondary diagnosis. If I have some time to discuss few more topics. This is not my case, took it from Radiopedia today morning. This fellow was from Iran, I suppose, that article. This is new to me. This is Hermansky-Pudlak syndrome, where you see lung fibrosis, reticulations and all, mild proximal bronchiectasis, subpleural reticulations. So this is a triad of symptoms: oculocutaneous albinism, platelet dysfunction, chronic cough due to pulmonary interstitial fibrosis. This is Hermansky-Pudlak syndrome. And this one, Bird-Hawk syndrome. You will see we have already discussed cystic diseases, and in this there are lower lobe predominant cyst. LCH, there is sparing of lower lobe. In Bird-Hawk syndrome there will be predominant involvement of lower lobe and a regular shaped cyst will be there. In addition, you will see renal lesions which can be a chromophobe cell sarcoma or oncocytoma. These are some of the smoking related ILDs. To name some drugs causing ILD patterns: amiodarone, nitrofurantoin and chemotherapeutic agents. So the most common pattern is organizing pneumonia, NSIP, HP. Thank you all.
Thank you so much, sir, for such an engaging and enthralling session. Now, I request our Associate Professor Dr. Sumina ma'am to felicitate Dr. Suryaprakash, sir. Now it's time for the tea break. I would like to request you all to move forward to the waiting area outside for tea. We will resume the session here in 10 minutes. Thank you.